بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will discuss a new topic, which is one of the recently discussed topics in the clinical practice, especially in the radiology practice, and this is what is known as IgG4 related diseases. Actually, this is an important item that we have faced many of the lesions related to this topic, but they are sporadically distributed throughout the literature. What's the IgG4 related diseases? This is a group of chronic, relapsing, and remitting inflammatory conditions. They are characterized by tissue infiltration by lymphocytes and IgG4 secreting plasma cells with variable degrees of fibrosis as detected on histopathology. These lesions have common criteria. One of the most prominent criteria is their very good response to corticosteroid therapy. In about 50 to 70% of patients, the serum IgG4 is elevated. The normal level of the IgG4 is, let us to say, from 5 to 105 milligram per liter. Then the characteristic histopathologic appearance is one of the major diagnostic criteria. These lesions should be diagnosed accurately and treated thoroughly, because they may lead to organ dysfunction or even organ failure if not treated. Then the major representatives of this IgG4 related diseases are mainly located in the abdomen and pelvis, in the head and the neck, and to a lesser extent in the chest. Those which are present in the abdomen include one of the most important features, which is the autoimmune pancreatitis, then the sclerosing cholangitis, then the IgG4 related hepatopathy and related cholecystitis, tubulointerstitial nephritis, retroperitoneal fibrosis, inflammatory aortic aneurysm, and prostatitis. In the head and the neck, we have Mikulic's disease, sclerosing sialadenitis, sclerosing dacryoadenitis, Kuttner tumor, orbital pseudotumor, Riddle's thyroiditis, hypertrophic pachymeningitis, and hypophysitis. In the chest, we may have the fibrosing mediastinitis, inflammatory aortic aneurysm, also as in the abdomen, IgG-related lung and pleural disease, and also maybe pericardial disease. Then, actually, these lesions, according to the literature, are generally not painful, but some of the presentations may be present, like weight loss and jaundice, especially in cases of affection of the pancreas or the biliary tree or the liver. Lymphadenopathy is one of the common presentations of this disease, and they almost present in about 40% of the cases. Sometimes lesions are incidentally detected and can be easily misdiagnosed as malignancies, especially in the pancreas, for example. Then there are common histopathologic findings for this IgG4 related diseases. Number one, dense lymphoplasmacytic infiltrations, predominance of IgG4 positive plasma cells, some degree of fibrosis, and obliterative phlebitis and eosinophilia. Then the epidemiology of these diseases these are usually present in the middle-aged and older males, while if the lesion is present in the head and the neck, there is an equal male to female ratio in elevation of the IgG4 in the serum or in the tissues affected by the disease is not specific for these related diseases, since it can be found in other diseases like multicentric Castleman disease, allergic disorders, eosinophilic granulomatosis, Churg-Strauss disease, sarcoid, and other conditions. Then we depend for the diagnosis on some of the characteristic imaging findings, some of the laboratory findings, and the considerable or the prominent response of these conditions to corticosteroids. We have, as I have mentioned, a lot of diseases in the orbit, in the CNS, in the lymph nodes, in the biliary tract, retroperitoneum, GIT, thyroid, mediastinum, salivary, and the lacrimal glands. We start by the major topic in this group of diseases, which is the acute pancreatitis. Acute pancreatitis, autoimmune pancreatitis, is seen in about 50% of the patients with chronic pancreatitis. Actually, the elderly and middle-aged men are primarily affected. 95% of the patients are older than 45 years, and there is a male predominance here of about 7 to 1. 6% of the patients had surgery for presumed carcinoma. This disease may be mistaken for a pancreatic malignancy, and some of the patients were operated upon to remove pancreatic malignancy, but finally they found it as an autoimmune pancreatitis. One of the common features of this group of the diseases is their metabolic activity on PET-CT and the considerable response to steroid treatment. On imaging, the affected pancreas is diffusely swollen and it has a sausage-like appearance on ultrasound and also on CT and MRI. And on ultrasound, the disease is diffusely hypoechoic. In most of the diseases affected or related to this particular group, they appear of hypoechogenicity on ultrasound. And if the disease is focal in the pancreas, which is seen in about 35% of the cases, it is difficult to be differentiated from carcinoma. Then on CT and MRI, you see that the pancreas is diffusely swollen and it shows some delayed enhancement due to the presence of parenchymal fibrosis. And this sign, which is known as capsule-like rim, indicates that the pancreas is almost totally surrounded by a relatively hypodense, hypoenhancing rim, which forms what looks like a capsule. This is seen on CT, and on MRI, this rim is of black signal or hypointense signal on T2. According to the literature, they assume that this rim is due to fluid, and I don't think so, as it appears black on T2. Maybe a phlegmon, or most likely it is due to fibrosis. This sign is observed in about 30% of the cases on CT and 35% of the cases on MRI, and it is considered by some of the literature as one of the characteristic or even pathognomonic or signs of autoimmune pancreatitis. Then this is once more, the pancreas is diffusely swollen, it is homogeneously enhancing, and the pseudocapsule or the hypodense rim is seen around the pancreas. And this is the appearance by CT, where you see the pancreas is swollen and there is what looks like a capsule surrounding the pancreas, and this is its appearance by MRI T2 weighted image, where you see the rim or the halo as a low signal intensity shadow. This is another example of autoimmune pancreatitis with a capsule or a pseudocapsule of low signal intensity. And also you may notice that the gallbladder is also involved by the same disease, and this is known as IgG4 cholecystitis, where the wall of the gallbladder is diffusely thickened, as I will mention later on. Then this is the diagnostic features of autoimmune pancreatitis. And you remember that this pseudocapsule or rim is one of the diagnostic criteria. Then you should remember that in cases of pancreatitis, you can see pseudocyst formation, and you can see calcification in chronic pancreatitis, and you can see peripancreatic fat stranding. All these features are not seen in cases of autoimmune pancreatitis. Then this is the one of the examples where the patient received corticosteroids, and in the before therapy you got swelling of the pancreas, homogeneous enhancement of the pseudocapsule. Then after corticosteroid therapy you got regression of the lesion with restoration of the normal pancreatic density. One of the valuable techniques for detection of this disease or detection of an inflammatory lesion and inflammatory lesions at many sites in the body is the gallium citrate scan. And this scan can be used to spot other sites of IgG4 related disease. In these images, you can see that the lacrimal glands, the right salivary gland, some of the mediastinal lymph nodes are involved by this disease. Then on CT, on MRI, we have described the pancreatic pseudocapsule or the rim, the halo around the pancreas. Also, there are some changes in the biliary ducts, including the what's known as the duct penetrating sign. Whenever you look to the autoimmune pancreatitis and you got swelling of the pancreas, if you look to the duct, then while the duct is crossing through the site of the lesion, and you got tapering of the duct, which is um, usually referred to in the literature by the ice pick sign. And you see that the duct is narrowed, then it became wider after crossing the site of the lesion. And this is not seen with malignancies, of course, because malignancy will destroy the duct and will invade the surrounding structures. Then we came to the second abdominal manifestation of this group of the diseases, which is the sclerosing cholangitis. Sclerosing cholangitis is different from the primary sclerosing cholangitis. This is an autoimmune or IgG related sclerosing cholangitis. And you remember we have two types previously described in the literature, the biogenic or oriental cholangitis, that's primary sclerosing cholangitis, and now we have a new one, which is the IgG related sclerosing cholangitis, which is different from the primary sclerosing cholangitis. This is the most common extrapancreatic manifestation. In the literature, they consider autoimmune pancreatitis is the most bigger issue in this particular group, or the biggest issue in this group. Then it is followed by the sclerosing cholangitis. This sclerosing cholangitis rarely occur in absence of pancreatitis. Then, if you see the previously mentioned classic features of autoimmune pancreatitis, then it's easy for you to diagnose this as IgG4 sclerosing cholangitis. Actually, without the history, without the presence of autoimmune pancreatitis, and you see this is a case of cholangitis because you see dilated intrahepatic biliary radicals with beaded appearance and some strictures and some dilatations. Then, what is the difference between IgG4 sclerosing cholangitis and the primary sclerosing cholangitis? Number one, the tissue biopsy of IgG4 disease will detect IgG4 infiltration, plasma cells, and also interstitial fibrosis. There will be an increase in the IgG4 serum level above 135. You remember the normal level is from 5 to 105. Characteristically, these lesions respond well to corticosteroids. And of course, the presence of extrabiliary, in particular in the pancreas lesion, will help you to reach the diagnosis. Then, 70% of autoimmune patients with autoimmune pancreatitis will have involvement of the biliary radicals. The disease involves the intrahepatic as well as the extrahepatic bile ducts. There is one of the common features of this IgG4 related sclerosing cholangitis is the long and the continuous strictures. These long and the continuous strictures are not seen in oriental cholangitis and in primary sclerosing cholangitis. And also, one of the common features is isolated stricture, long stricture at the distal part of the common bile duct. And the differential diagnosis, of course, you may include cholangiocarcinoma, but the pathology, the other findings in the histopathology will help you to differentiate. Then this is the appearance of primary sclerosing cholangitis, and this is the appearance of IgG4 sclerosing cholangitis. In the primary type, you have band-like strictures, beaded appearance, prune tree appearance, and diverticulum-like outpouching. These are the features of primary sclerosing cholangitis. But in IgG4, you got long strictures and pre-stenotic dilatation, as you can see in the distal part of the common bile duct, one of the features of this disease. And also you got a long continuous types of strictures. And this is an example. You see structures by this ERCP, and also you may see that the distal part of the common bile duct is narrowed with proximal dilatation. Another example, then you see the beaded appearance of the pancreatic duct, and you see multiple long structures of the intrahepatic biliary radicals. Then these are some of the important information. And the circular and symmetric rind of soft tissue encasing the bile duct wall may be seen on CT, which may simulate the fibrosis whenever it occurs around the portal tracts. A smooth margin and the homogeneous enhancement in the delayed phase, and also the gallbladder can be involved by this disease, and at that time you will got a significant thickening of the gallbladder wall with hypoechogenicity at ultrasound and low signal intensity at T2 weighted image because of the presence of fibrosis with late post-contrast enhancement. This is the pancreas, which is swollen. The pancreatic duct is not dilated. ERCP showed long stricture in the proximal part of the common bile duct, and maybe another one in its distal end, and you got multiple strictures within the intrahepatic biliary radicals. Another example of IgG4 related cholangitis, and you see the long appearance of the strictures within the liver. Then the primary sclerosing cholangitis is known to occur in younger patients and is associated with inflammatory bowel disease like ulcerative colitis and Crohn's disease. And this is an example, and you see the manifestation of the Crohn's disease in the form of mural thickening and there's some stranding of the surrounding fat, and this is the appearance of primary sclerosing cholangitis. And also this is in another appearance where you can see the biliary radicals are dilated, and inside the bile ducts, and you can see multiple calculi. And you remember that we discussed in the lecture of biliary imaging that the stones in the bile ducts are one of the criteria for oriental cholangitis or biogenic cholangitis. Then the differential diagnosis is oriental cholangitis in this case, but the patient, according to the literature, is not Asian, and there is no history of parasitic infestation, and the diagnosis of biogenic or oriental cholangitis is unlikely. Then you know that there is about 8% of patients with primary sclerosing cholangitis may develop biliary calculi. This is an important issue to be noticed. The disease usually shows favorable response to corticosteroids. Then it is strongly recommended that steroid trials should be avoided. If you decided to give the patient a steroid therapy, you should give the full course because some of the malignant lesions may improve on steroid treatment, like lymphoma, for example. Then a relapse may occur in some patients even with corticosteroid therapy. Then we came to the issue of IgG4 cholecystitis, and here you see a similar example to the previously shown one, and the gallbladder has a diffuse mural thickening of low signal intensity on T2 weighted image. You remember that I have presented some of the cases with these Rokitansky-Ashoff nodules in the wall of the gallbladder, which may help to diagnose adenomyosis of the gallbladder. But here you do not see these nodules, And also, you do not see significant inflammatory changes around the gallbladder. You remember that this lesion may simulate densogranulomatous cholecystitis, and you remember also that densogranulomatous cholecystitis in some cases cannot be differentiated from gallbladder cancer. Then cholecystectomy was performed, and it showed IgG4 related cholecystitis. Another example where the gallbladder wall is non-uniformly thickened, highly suggestive of a gallbladder carcinoma, and after surgery it was proved to be IgG4 related cholecystitis. And in this example, you see that the gallbladder wall is diffusely thickened and enhanced, and you may diagnose acute cholecystitis. But if you look to the pancreas and see the pancreas is diffusely swollen, the head, the body, and tail, and the characteristic pseudocapsule or halo, hypodense halo around the pancreas is present, suggestive of autoimmune pancreatitis. Then this is autoimmune pancreatitis, and this is autoimmune or IgG4 related cholecystitis. Another example, you see intrahepatic biliradical dilatation and abnormal enhancement in the region of the gallbladder, as well as the surrounding or the adjacent liver parenchyma. This may raise the possibility of xanthogranulomatous cholecystitis, but it has been proved to be IgG4 related cholecystitis. Then we came to the affection of the kidneys, and this may be present in up to 35% of patients with autoimmune pancreatitis. Affection of the kidney may be one of the five patterns. Number one, bilateral wedge-shaped peripheral cortical lesions, like this example, which are the most common appearance. Diffuse patchy involvement of the kidney, a rim of soft tissue around the kidney, like the pseudocapsule around the pancreas, bilateral nodules in the renal sinus, diffuse thickening of the renal pelvis. But this is, of course, is the most common appearance, which is patchy, wedge-shaped hypo-enhancing lesions within the renal parenchyma. And this interstitial nephritis, no hematuria is present, and the lesion responds well to corticosteroids. And this is another example, and you see multiple patchy areas in the kidney, and the lesions are slightly non-enhancing compared to the enhancing normal renal parenchyma. Another example, and you see here the patchy areas of the kidney. If you look to the pancreas, and you can easily appreciate the swelling of the pancreatic head, and if the pancreatic body and tail were included in the scan, this may show the specific findings of autoimmune pancreatitis, which will help you to predict that this appearance of the kidney belongs to the IgG4 group of lesions. And this is the one of the confirmatory signs that here you see multiple patchy areas in the renal parenchyma, and after corticosteroid therapy there is considerable response and regression of the disease. Another appearance, and you see patchy areas within the renal parenchyma, and this is one of the also manifestations I will mention after a few minutes, which is the periaortitis. And this is also an IgG4 related disease where you got is an enhancing soft tissue lesion around the aorta, which is totally different from retroperitoneal fibrosis. Then one may ask that You have mentioned before that whenever the kidney is infiltrated by multiple non-enhancing lesions, and this may point to the affection of the kidney by lymphoma. And that's true. If you try to differentiate between both on the on isolated imaging only, this is a very difficult situation because the lesions share many of the diagnostic criteria, like the patchy non-enhancing areas. They respect the renal contour, they show metabolic activity, but one of the helpful diagnostic criteria of this IgG4 related diseases is the presence of another disease in the abdomen or elsewhere in the body. And the presence of periaortitis or this inflammation around the aorta, or if you see the features of autoimmune pancreatitis, this will help you to reach the diagnosis. But sometimes it is difficult, and we may have tissue biopsy to confirm the diagnosis. And this is the appearance of IgG4 related disease, which may simulate lymphoma or may simulate renal deposits, may simulate renal infarctions, for example, or may simulate the striated form of acute pyelonephritis. And rarely, the IgG4 related renal disease may appear as a focal renal mass, which cannot be discriminated from renal cell carcinoma. But as I have mentioned before, in patients where you can detect pancreatic affection, it may help you to predict the possibility of IgG4 related disease. The presence of renal lesions in patients with pancreatic disease can help to differentiate autoimmune pancreatitis from pancreatic cancer, and this is also one of the opposite ways to use both facts. If you see patchy areas in the kidneys with focal area in the pancreas, which simulates pancreatic cancer, then you may predict that all of these belong to IgG4 related disease. Then you remember that I have mentioned something about mesenteric panniculitis, which is an idiopathic disorder, and this is a chronic non-specific inflammation of the mesenteric fat, usually present in elderly patients, and many times it is asymptomatic, but sometimes it presents by abdominal pain or intestinal obstruction or ischemia or a mass like lesion or diarrhea. Then the disease is said to pass through the three stages: the stage of degeneration of the mesenteric fat, then mesenteric inflammation, which is known as panniculitis, then fibrosis, which is known as retractile mesenteritis or sclerosing mesenteritis. And this example, you see a lesion which is involving in the mesentery, and you can see the radiating fibrous bands from the lesion with dense matrix calcification and some air fluid levels in the intestine denoting intestinal obstructive changes. And this is also another example of sclerosing mesenteritis with a mass-like lesion, multiple fibrotic bands radiating from it, central area of calcification, and multiple air fluid levels denoting intestinal obstruction. Sclerosing mesenteritis may be associated with malignancies like lymphoma and the gastric carcinoma, recent abdominal surgery, systemic inflammatory conditions like retroperitoneal fibrosis, sclerosing cholangitis, radial thyroiditis, and orbital pseudotumor. All these lesions are also belonging to the IgG4 related disease. And this is the best example for the mesenteric panniculitis, where you got dirty appearance or the ground glass appearance of the mesenteric fat, and you can see the vessel fat sign, where each of the vessels in the mesentery is surrounded by a halo of the mesenteric fat, and this is one of the helpful diagnostic criteria. This is also an example of mesenteric panniculitis, where there is uh, uh, let us say, dirty appearance of the mesenteric fat, or a smudging of the mesenteric fat with the vessel halo sign, where the vessels are surrounded by a hypodense halo of fat. Another example, and then you see the uh, abnormal appearance of the mesenteric fat, and you see the vessels within the lesion surrounded by the halo of fat. Then the mesenteric panniculitis may proceed to sclerosing mesenteritis. Then a mass-like lesion will develop inside the abdomen, and it cannot be discriminated from other peritoneal or omental lesions, especially if you do not see some of these, let us say, strandy fibrotic bands and calcification. But if you see a disappearance, and you should have a biopsy in order to reach the diagnosis and to differentiate it from other mesenteric lesions. Then we have the retroperitoneal fibrosis, which is also related to this group of the diseases. It is a chronic inflammatory condition and may be associated with many underlying causes like infection, radiation therapy, some drugs, malignant tumors, and trauma. And 20% of the patient with autoimmune pancreatitis may be associated with retroperitoneal fibrosis. And in the era before CT and MRI, we used to diagnose retroperitoneal fibrosis whenever you see on the IVU film that the ureters are medially displaced, and there is some back pressure changes in one or both of the kidneys. Then this should be discriminated from what I have mentioned, the disease known as periaortitis, where you got an inflammatory lesion surrounding the aorta, and this is not a stenotic lesion and does not affect the ureters. In periaortitis, the aorta itself is dilated, and it may be the seat of an aneurysm. And this is the retroperitoneal fibrosis as seen on the intravenous urography. On the plain film, you may see marginal calcification of a soft tissue tumefaction. Then an IVB, and then you got some deviation of the ureters near to the spine, with some back pressure changes on both kidneys. And in the 15-minute film, you can see marked hydronephrotic changes with distension of the ureters that are medially displaced. But CT is one of the best modalities for the diagnosis. On CT, you can see a soft tissue mass that is encircling or encasing the aorta as well as the IVC, and it will entangle both ureters, resulting in some back pressure changes in both kidneys. And the lesion may also extend to involve or to encase the common iliac arteries. Then this is the follow-up of the previous case. This is the case, and here is the follow-up after steroid therapy, and you got significant, if not total, regression of the disease. Another appearance of retroperitoneal fibrosis encasing the kidney, encasing the aorta, with back pressure changes on both sides. And this is the reformatted images, and you see the dilated pelvic cell system on both sides, and the medial displacement of both ureters. In this case, you got an enhancing soft tissue density encasing the aorta as well as the common iliac arteries with and the left kidney is surrounded by a halo of fluid density, and this halo was proved to be just leaking urine. And in the delayed film, you can see that the contrast material is now in the perinephric fluid, diagnostic of urinoma, and this may be the result of a compression of the ureter and back pressure changes on the collecting system. And IgG4 prostatitis is rarely considered as an initial diagnosis. You know that there are a lot of lesions that can involve the prostate. So it is very difficult to diagnose IgG related prostatitis as in a single entity. And even in patients with other IgG4 related diseases, you cannot also diagnose this as IgG4 related prostatitis. The symptoms are almost similar to the symptoms of prostatic enlargement. The PSA level may be normal or slightly elevated, and by imaging, the prostate is enlarged, similar to benign prostatic hyperplasia. The disease affects the central part of the gland and spares the peripheral zone of the gland. But the histopathology and the immune histochemistry are very helpful if you have a biopsy from the prostate and you got the infiltration by plasma cells and lymphocytes with elevation of the IgG4. And if you look to this case, yes, you can see that the prostate is enlarged with heterogeneous density and the feeling that there is what looks like an abscess inside the prostate. And this cannot be, as I have mentioned, diagnosed as IgG4 related disease. Another example, which has been proved by biopsy, is the prostate is enlarged, indenting the bladder based on CT. It shows the characteristic hypoechoic texture with significant metabolic activity. All IgG4 related diseases are metabolically active. Then we came to the head and neck abnormalities, starting by the hypertrophic meningitis. Yeah, by meningitis, we mean the dura, which is markedly thickened and enhanced, while the leptomeninges are the arachnoid and the Debye matter, which have been mentioned before, and we also discussed the differential diagnosis. The disease is also seen in elderly patients, and most of the patients are asymptomatic but they may present by headache. If you have the serum level of the IgG4 or the analysis of the CSF for IgG4, they are positive. Then, if you look here, and you can see that there is a diffuse meningeal thickening and enhancement. Then on the follow-up, it does not show significant improvement. The second follow-up shows worsening of the disease, and the fourth follow-up showed some in the after treatment by this drug. 6 months follow-up MRI showed significant regression in the disease process, especially of the tentorial leaflet. Then hypertrophic meningitis means diffuse thickening and enhancement of the dura. And if it is focal, it may simulate a meningioma. These are the characteristics on MRI. On the T1, the lesion is iso-intense. If you inject the contrast material, you got homogeneous enhancement. On the T2 and the FLAIR images, you got markedly hypo-intense due to fibrosis. Then the role of PET-CT in meningitis is limited because of the ground metabolic activity of the brain. PET-CT can look for other organs affected by the same disease and can be used for the detection of the response to treatment. Meningitis is differentiated from meningioma en bloc, infectious hypertrophic meningitis, and histiocytosis, including Erdheim-Chester disease and Rossi-Deformand disease. I will mention some words about both diseases. Neurosarcoid, intracranial hypotension. I will also measure something about it. Then granulomatous diseases, especially the TB. What is Erdheim-Chester disease? This is a rare, non-Langerhans cell, non-familial, multi-systemic granulomatosis. And there is infiltration of some of the tissues by lipid-laden histiocytes, which are known as foamy macrophages. The common presenting symptom is bone pain, and the musculoskeletal involvement is the most common by this disease. While you got multifocal extraskeletal involvement in up to 40% of the patients, and the skeletal changes will not be discussed here, but I will concentrate on the head and the neck manifestations. Also, some lesions will appear in the lung, which are similar to histiocytosis of the lung in the form of multiple cystic diseases. Then retroorbital soft tissues with extension along the optic nerve to the hypothalamus, and this is an example. These soft tissues are bulky and they are strongly enhancing, and if on MRI you see a significant low signal intensity on T2 weighted image. Intracranial involvement of the dura and the brain or the pituitary gland is rare. Dural accumulations may also mimic a meningioma. This Erdheim is one of the differential diagnoses of meningitis. Pulmonary fibrosis and cardiac failure are the common causes of deaths in this disease. And on MRI T1 weighted image, you see big masses in the retroorbital area, and if you inject contrast material, you got significant enhancement. And this is also one manifestation of Erdheim-Chester disease. You got intermediate signal dural-based masses, very low signal intensity on T2, significant or marked contrast enhancement on post-contrast images. Then this is easily differentiated from, let us say, tumors, and most of the tumors will show either intermediate signal on T2 or even high signal on T2 weighted images, but they do not show the very dark signal. And then one may say, what about the fungal infection of the brain? And you know that in fungus, it's true that the fungus will appear of intermediate signal in the T1 and dark signal in the T2 and strong contrast enhancement, but this is an infection which should be surrounded by significant perifocal brain edema, and the clinical will help in the differential diagnosis. Then what are the differential diagnoses of Erdheim-Chester disease? Number one, which is previously mentioned, is the meningitis. Then, which will be mentioned, intracranial hypotension, spontaneous hypotension, hypotension due to CSF drainage, and the infection like TB, fungus, and syphilis, lymph disease. Then T cell lymphotrophic virus type 1, necrotizing otitis externa, which is caused by Pseudomonas. Then systemic autoimmune diseases, which may result in significant dural thickening and enhancement like Wagner granulomatosis, sarcoidosis, Sjogren disease, temporal arteritis, malignancy, dural metastasis, and meningioma. This is the Rosy deformans disease, which is a rare, benign, idiopathic proliferative disease that involves the phagocytic histiocytes. Then the exact cause is unknown, but the disorder of immune regulation or viral infection are suspected. The disease mainly affects young adults in the range of 20 years of age with slight male predominance. About 80% of the patients will present by painless, massive cervical lymphadenopathy. And some of the presentations may be present like fever, malaise, weight loss, and night sweats. In cases of intracranial involvement, which is considered rare, the patient may complain of headache, seizures, or sometimes pituitary dysfunction. Then, what are the manifestations of this disease? Number one is nodal involvement with enlargement, diffuse enlargement, significant enlargement of the nodes which are homogeneous and strongly enhancing. The most affected group of lymph nodes are the cervical, then you may have other groups. Extranodal involvement is seen in about 30% of the cases where nodules are present in the lung, in the skin, in the nose, in the orbit, in about 7% of the patients, and in the bone. Intracranial and intraspinal affection is rare, while if you have CT, you will got hyperdense meningeal based masses with significant contrast enhancement, and sometimes you got some edema around the lesions. And you see here sheets of meningeal based enhancing lesions, which are sometimes they are unilateral or bilateral. On MRI, the lesions are iso-intense on the T1 and the hypo-intense on the T2 with significant homogeneous enhancement. Then if you look to this example and you see big soft tissue masses within both orbital cavities with marked displacement of the globes and the stretching of the optic nerve, then one may think of orbital lymphoma, for example, and this is of course one of the basic differential diagnoses from this disease. Then many times it's easy to have a biopsy and confirm the diagnosis. Another example of a big intracranial supracellular mass with meningeal thickening along the dorsum celli and along the greater wing of the sphenoid bone. Another example where in the FLAIR image you got low signal, on the T2 weighted image you got low signal, on M post contrast enhancement, significant enhancement, and diffusion free. Then we came to the one of the causes of diffuse thickening and the enhancement of the dura, which is known as the spontaneous intracranial hypotension. Hypotension means that you have this triad: low CSF pressure, orthostatic headache, and that's to say headache when the patient position is changed. Then by imaging, you got diffuse meningeal enhancement. The incidence is rare, as you can see, 5 per 100,000 per year, and the peak of age is around 40, and the female predominance is known. Then what is the cause of intracranial hypotension? It is the leak of CSF into the epidural space through a defect, whatever this defect is due to. Then these are the suspected causes including the traumatic etiology, of course, like the accidents, sport-related injuries, epidural catheters, and nerve root avulsion. Then some of the spontaneous etiologies like meningeal diverticulitis, which accumulate CSF leading to decreased pressure, calcified disc herniation, which injures the dura leading to CSF leak, speculated osteophytes, the same mechanism, CSF venous fistula, leakage of the CSF into the venous side, then weakness of the dural sac due to connective tissue disorders, which may lead to dural ectasia and consequent decrease in the CSF pressure. 80% of the patients will have diffuse nodular pachymeningeal enhancement, similar to the previously mentioned IgG4 pachymeningitis. And the leptomeninges, the bea and the arachnoid are not involved. The brain sag, which is almost similar to the Chiari-1 malformation, and you got downward displacement of the tonsil of the cerebellum below the level of the foramen magnum. And other findings may include obliteration of the prepontine cistern, flattening of the bones, draping of the optic chiasm over the dorsum celli, which is displaced backward, subdural hygroma or hematoma, enlargement of the pituitary gland, ventricular collapse, and engorgement of the dural venous sinuses. And I think that this is one of the helpful diagnostic criteria. If you see diffuse pachymeningeal thickening and enhancement associated with dilatation of the dural venous sinuses, you may spot the diagnosis of spontaneous intracranial hypotension. And this is an example of diffuse dural thickening and enhancement. And you may feel that there is some prominence of the dural sinuses, but here is a good example. If you see diffuse meningeal thickening and enhancement with engorgement of the dural sinuses. Another example, and you see the downward descent of the tonsils of the cerebellum through the foramen magnum. You can see also the obliteration of the prepontine cistern with diffuse thickening and enhancement of the leptomeninges. One of the signs is also what is known as the drooping sign of the corpus callosum. That the splenium of the corpus callosum is not in a horizontal position like usual. This is the normal appearance of the corpus callosum, and this is the drooping sign. Actually, it is difficult to be noticed, but it is mentioned as one of the signs. Then IgG4 related hypophysitis. You remember in the lecture of the cell, we have mentioned many types of hypophysitis, and this is also another type which is known as IgG4 related hypophysitis. There is involvement of the pituitary gland, and according to the pituitary involved, the symptoms will appear. Anterior pituitary will lead to hormone deficiencies with hypothyroidism and hypogonadism, and mass effect on the optic chiasm. Posterior pituitary will lead to diabetes insipidus. Panhypophysitis will include all of these symptoms. On imaging, and you got the diffuse enlargement of the pituitary gland with or without enlargement of the stalk, and both will show contrast enhancement. And sometimes you may see IgG4 related hypertrophic pachymeningitis. And here is an example. This is the sagittal before contrast and the sagittal after contrast. You got prominence of the pituitary gland with thickening and enhancement of the stalk, and the patient is complaining of diabetes insipidus. You remember that I have mentioned that there are three differential diagnoses for this appearance, including sarcoid, and the lymphocytic hypophysitis, and the Langerhans histiocytosis. Then in the literature, I mentioned sarcoid. You may include lymphoma, metastatic disease as well. And if the patient is a child, you may add Langerhans histiocytosis. Then you cannot reach the diagnosis of IgG4 hypophysitis without biopsy. And this is before treatment and after treatment of another case. In the pre-therapeutic stage, you got enhancement and enlargement of the gland as well as the stalk, with almost resolution of the disease and normal appearance of the pituitary and the stalk. Another appearance of IgG4 hypophysitis before contrast and after contrast. They may sometimes put some of the measurements for the pituitary gland and the stalk, and they compare these measurements with the normal standard measures. Then the differential diagnosis of IgG4 hypophysitis include the pituitary adenoma, of course, the craniopharyngioma, suprasellar meningioma. This is not the case. Pituitary metastasis, lymphocytic hypophysitis, neurosarcoid, densitomatous hypophysitis, and the recrotizing hypophysitis. Then affection of the lacrimal glands, IgG4 dacryoadenitis, and this is uh, you remember Mikulicz and the Sjögren disease. They may affect the one of the lacrimal glands or both. Frequently, the lesion is bilateral, and you remember that in the differential diagnosis of bilateral lacrimal gland enlargement are the autoimmune diseases like Sjögren and the Mikulicz disease. Then this is an example of an IgG4 related bilateral lacrimal gland enlargement. The biopsy of the lacrimal gland showed fibroinflammatory lesion with plasma cells and eosinophils. Then another example by MRI, bilateral almost symmetrical lacrimal gland enlargement. If you inject contrast material, they enhance significantly, and you need the biopsy to confirm the diagnosis. But you include this in the differential diagnosis, of course. And this is another example, bilateral almost symmetrical lacrimal gland enlargement with homogeneous enhancement. And this will represent a systemic disease, including autoimmune diseases like Mikulicz, Sjögren, sarcoid, and then you include lymphoma, Wagner granulomatosis, and other lesions, and also you include this disease, which is IgG4 related. Another appearance of involvement of the uh, the lacrimal glands and some of the extraocular muscles as well. The gallium citrate scintigraphy showed that there are also mediastinal lymphadenopathy, which are also detected by PET scan. Sjögren and Mikulicz are almost similar lesions, or they are similar to each other in the imaging appearance, bilateral almost symmetrical enlargement of the lacrimal glands with homogeneous enhancement. Then affection of the salivary glands also can occur in the course of IgG4 related diseases, and the affection of the lacrimal gland previously was called Mikulicz disease, and also the submandibular gland involvement was previously called Kuttner disease. The lesions will result in enlargement of the affected gland with significant post-contrast enhancement. And autoimmune pancreatitis is detected in about 17% of patients with sialadenitis. Then this is an example. You see that both post-parotid glands are significantly enlarged and they enhance after injection of contrast material. And you remember that all the IgG related diseases will show metabolic activity on PET CT. As you can see here, there are bilateral, almost symmetrical enlargement of the lacrimal glands, of the parotid glands, showing homogeneous contrast enhancement. And this is the lesion which was previously known as Kuttner tumor, which can affect one of the submandibular salivary glands, or may affect both, or may also involve other salivary glands. The lesion will appear as a firm swelling, which may simulate a tumor. And there is recurrent pain and swelling. Sometimes the patient is asymptomatic. Salivary stones may be present in up to 55% of the cases. And this is an example where you got significant enlargement of the right submandibular and both parotid glands, which are homogeneously enhanced and uh, they appear significantly enlarged and homogeneously enhanced. Another example of Kuttner disease where there is bilateral symmetrical enlargement of the submandibular salivary glands showing homogeneous post-contrast enhancement. And the differential diagnosis, you may include TB, Sjogren disease, and lymphoma, and you reach the diagnosis of IgG4 related disease by biopsy. Then here you got let us say, the appearance, which is highly suggestive of autoimmune pancreatitis with a pseudocapsule or hypodense halo around the pancreas. Then you see bilateral symmetrical enlargement of the lacrimal glands and also symmetrical enlargement of the submandibular salivary glands. And this is another example where the submandibular salivary glands are involved as well as the pancreas. You see the halo of low signal intensity around the lesion, the pancreas, and this is the follow-up after steroid therapy. You may see some regression in the size of the submandibular salivary glands, as also the pancreas. Then you remember orbital pseudotumor, which is an idiopathic inflammatory condition, commonly involves the extraocular muscles, may involve the uvea, the sclera, the lacrimal gland, and the retrobulbar soft tissues. The condition is unilateral in about 90% of the cases. However, it can be bilateral. The patient presented by painful proptosis and diplopia. Then the response, uh, uh, if the lesion is not responding well to corticosteroids, then you may have a biopsy to confirm the diagnosis. That we have thought that the orbital pseudotumor, whenever it affects the extraocular muscle, it has a predilection to the lateral rectus. But sometimes you may got medial rectus involvement or medial and lateral rectus involvement. Together with stranding and dirty fat appearance, thickening of the posterior sclera, and you see here the classic appearance of smudging or stranding of the fat. And this is an example of involvement of the medial and the lateral recti muscles. And also this may be associated with enlargement of the lacrimal gland and stranding of the retroocular fat. And this is another example of orbital pseudotumor. You see obliteration of the fat by ill-defined hypointense lesion, and this lesion is of intermediate signal in the T2 with somewhat enhancement and diffusion restriction. Then do you think that this is Erdheim-Chester disease? No, because the enhancement is not that strong. and you got the lesion in the T2 weighted image is not of very dark signal. Then in the differential diagnosis, orbital cellulitis, you know that orbital cellulitis is diagnosed whenever there is ismoidal sinusitis, Wagner granulomatosa, and lymphoma. Then one of the lesions related to the thyroid, which is the Riedl's thyroiditis. IgG4 related thyroid disease is the Riedl's thyroiditis, which where there is extensive fibrosis of the thyroid tissue, resulting in a very firm, stony, hard, asymmetrically enlarged the thyroid gland. Then this disease, as you remember, is related also to some of the IgG4 related diseases like sclerosing cholangitis and retroperitoneal fibrosis. And sometimes it is difficult to differentiate this from thyroid carcinoma or thyroid lymphoma. But one of the very good diagnostic criteria is the very dark signal on T2 weighted image due to fibrosis and the strong homogeneous post-contrast enhancement. And this is an example. You see the thyroid gland is dense due to fibrosis in the CT, and this arrow points to a small preserved normal thyroid tissue in the anterior aspect of the right thyroid lobe. And then the T1 weighted image, the T2 weighted image shows very dark signal of the thyroid and enhancement after injection of contrast material. Another example of Riedl's thyroiditis, you got homogeneous hyperdensity of the thyroid gland, low signal in the T1, very low signal in the T2 weighted image, and calcium may be present in this Riedl's thyroiditis. Another example, you see a strong enhancement of the enlarged thyroid gland, marked hypoechogenicity on ultrasound. Then the lymph nodes are one of the manifestations of IgG4 related disease. They are present in about 40% of the patients. You know, if the patient had generalized lymphadenopathy, then you consider sarcoid, Castleman, infection, lymphoma, metastasis. But the nodes that are present in IgG4 related disease are those which usually refer to as reactive lymphadenopathy. The nodes are slightly enlarged. They have distinct histologic appearance on biopsy. They are not associated with constitutional symptoms. Their size do not exceed 2 centimeters, and they respond well to corticosteroid therapy. Then hilar lymphadenopathy is present in about 80% of patients with autoimmune pancreatitis. And sometimes, if you look carefully to these nodes, you may remember the sarcoid nodes, which are homogeneous, discrete, and may show calcium. This is exactly the appearance of the IgG4 related lymphadenopathy. And you got a small lymphadenopathy in the mediastinum. They are homogeneous, and they do not contain calcium in such an example, but usually we report these nodes as as reactive lymphadenopathy, and we do not usually say that this is IgG4 related lymphadenopathy. Then these are also, if you look carefully, you may remember the sarcoid lymph nodes, and here there is some reactive pleural thickening on both sides, which is more prominent on the right side. In the lung, IgG4 related disease is present in about 15% of patients with autoimmune pancreatitis. And if you have a patient with autoimmune pancreatitis and a lesion in the lung, then you may relate both to the IgG4 condition. And the appearance of the lung involvement may be in the form of a solid nodular or mass-like lesion, which may simulate bronchogenic carcinoma, round ground glass opacity, alveolar interstitial disease, or broncho disease. Then inflammatory pseudotumors in the lung, we have mentioned before in the lecture of soft tissue tumors, and they may belong to the IgG4 related disease. And bronchovascular disease is associated with lymph node enlargement, and the differential diagnosis from sarcoid is well known. Then this is what we call an inflammatory pseudotumor, but you cannot say that if you see a mass in the lung. We have agreed that a mass in the lung of an adult should be considered as a bronchogenic carcinoma until proved otherwise. And this mass will be biopsied, of course, and the biopsy showed that it is a fibrous pseudotumor or inflammatory pseudotumor, which is related to IgG4 disease. And this is also another example which looks like an aggressive lesion. And you remember that these lesions are metabolically active. Then, if you have the PET scan, you may highly suspect the bronchogenic carcinoma, and consequently, the patient will have biopsy to confirm the diagnosis. And this is also another example. You see the ground glass infiltrations, which are bilateral, and there is good response to corticosteroids, which is exactly similar to what have been mentioned before about the Sherb-Strauss disease. And finally, the periaortitis or the periarteritis, which is an inflammatory reaction occurring around the aorta and also some of the vessels, especially the common iliac arteries. There is some urinary tract involvement, and the hypertension and smoking are not risk factors for this disease. There are 5 types of aortic involvement. The most common is type 1, type 2, which involves the infrarenal abdominal aorta as well as the iliac arteries. And type 1 is confined only to the infrarenal aorta. And type 3, involvement of the ascending and aortic arch are added to type 2. And type 4 is the rarest one, where there is no involvement of the aorta but involvement of the common iliac arteries. And type 5 is other involvement of the aorta not mentioned here. Then if you look here and you see is a soft tissue lesion which is enhancing surrounding the aorta and also surrounding the left common iliac artery. And this patient had a known history of autoimmune pancreatitis. And one of the helpful diagnostic signs, as I have mentioned, is the luminal dilatation. The aorta is somewhat dilated compared to the aorta surrounded by the retroperitoneal fibrosis, which is not dilated. Also, the periaortitis do not involve the ureters, and it responds very well to the corticosteroids. The above images, the upper images showed the distribution of the disease, and the lower images showed the response to corticosteroids. And this is also another example of periaortitis with an IgG4 related lesion in the lung. And here also you see periaortitis with significant soft tissue enhancing mass around the aorta, and it appears of low signal intensity in the T2 weighted image with diffusion restriction. The follow-up after 3 weeks of steroid therapy showed a significant resolution of the disease. And this is one of the manifestations of periaortitis and weakness of the wall, resulting in what's known as inflammatory aneurysm of the aorta. And you see the aneurysm with patent lumen and thrombosed lumen before steroid therapy, and after steroid therapy you got significant reduction of the inflammation of the wall of the aorta, and also you may see that the aortic caliber has also reduced. Thank you very much. Walhamdulillah.